Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Madrigal Pharmaceuticals.
Hello, I'm Manela Abdulmalik. I'm a professor of medicine at the Mayo Clinic in Rochester, Minnesota, and also director of the MASLD Clinical Research Program. Welcome to this Medscape program entitled Multidisciplinary Management of Metabolic Dysfunction-Associated Steatohepatitis. I'm very pleased to be joined today by Dr. Fernando Brill, who's an assistant professor in the Division of Endocrinology, Diabetes, and Metabolism at the University of Alabama in Birmingham, and by Miss Ann Moore, who's a nurse practitioner at Arizona Liver Health in Chandler, Arizona. Welcome, Fernando and Ann. So delighted that you could be with us here today.
Great to be here.
It's a pleasure.
So, today we're going to be discussing the diagnosis and management of metabolic dysfunction associated steatohepatitis, or MASH, from a multidisciplinary perspective. Fernando, I believe you see this very often in your clinical practice, and you have a case to share with us to get us started.
Yeah, that is correct. So let's discuss Jane. She's a 66-year-old female, non-Hispanic, and she has a past medical history of prediabetes, hypothyroidism, GERD. She used to smoke but quit 3 years ago, and she has coronary artery disease. She started post placement of a stent in 2023. She also mentions that she was told she had she has congestive heart failure, but there's no data in your chart, and she doesn't know for sure how that was diagnosed. There's no echocardiogram available. She's taking several medications, as you can see: aspirin, atenolol, losartan, metformin for the prediabetes, levothyroxine, pantoprazole, and rosuvastatin. Her physical exam is quite unremarkable, except for some peripheral edema. And then her BMI is 28.9 kilograms per square meter. She also brings some labs that she did last week, and you can see them on your screen. A1C 6.2, creatinine of 1.2 with an estimated GFR of 50, liver enzymes 30 and 19 for AST and ALT, lipid panel, hemoglobin, and platelets of 189.
Well, thank you, Fernando. Anne, what are your thoughts about this patient? Does this patient check all the boxes for risk for MASLD and MASH? How would you approach screening this patient in your practice?
So, this patient looks very much like many of the patients in my clinic. In fact, my whole waiting room, actually, on most days. And she definitely ticks the boxes for at risk MASH. She's pre diabetic, she's overweight, she has hypertriglyceridemia, coronary artery disease, which, by the way, is the number one cause of mortality in our patients with MASH. So that concerns me. And she's over the age of 50. So, yep, definitely I am concerned about her. And I know we're going to discuss this further, but I think we'd be off to a good start by calculating FIB4, perhaps.
Yeah. Is that your initial screening for patients? All patients that you might suspect have MASLD or MASH is the FIB4 score?
So, because I work in hepatology, typically the primary risk assessment has already been done by the time patients get to me. And I'm fortunate enough to have VCTE embedded in my office. And so, before I even walk into a room, my patient has had a VCTE, and I'm ready to go with an assessment at the beginning of the appointment, really.
Fernando, I'm curious, what would your initial assessment and screening approach be as an endocrinologist?
Yeah, I think we would rely on FIB4. That would be our initial step. I think it's a decent tool when you are working in primary care settings, in the obesity specialist or endocrinologist. As a first tool, just calculate a FIB4 to try to stratify that risk of liver fibrosis.
I think clearly all of us wear different hats, whether we're in primary care or endocrinology or hepatology. And I can just imagine the scenario where primary care physicians are seeing patients who are clearly enriched with obesity and metabolic syndrome, and their primary goal is to assess whether there's a hepatic complication of metabolic syndrome. Does a patient have MASLD or MASH? And to establish a timely referral pathway if that exists. Our endocrinologists really are seeing much more enrichment of diabetes. I mean, how many patients with diabetes can be seen in endocrinology? And we know that diabetes is the strongest predictor for fibrosis. And so maybe endocrinologist's vantage point is not just the presence or absence of steatotic liver disease, but really an understanding of severity. And I agree with Ann. By the time a patient reaches our hepatology clinics, there is already an enrichment strategy there that has happened either because of their multiple comorbidities, chronic elevation of liver enzymes, elevated FIB4, or transient elastography. And my concern becomes management of patients with advanced liver disease and the assessment of liver directed therapies in partnership with my colleagues. What are your thoughts with your respective hats of this allocation and pathway?
Yeah, no, I agree with everything you said. And I do think as endocrinologists, when we are facing type 2 diabetes, we know it's a strong risk factor to develop more advanced liver disease. So if you look at prevalence of clinically significant fibrosis in patients with type 2 diabetes, we know it's enriched. So when we are seeing patients in clinic, we need to think of liver disease the same way we think for kidney disease and we are screening with microalbumin, or we think of diabetic retinopathy, and we're sending patients to have an eye exam yearly. So the liver needs to be incorporated into our workflow when we are seeing patients with type 2 diabetes.
Yeah, Anna, there's no doubt our advanced practice providers are in the front line in caring for these patients, both in primary care and hepatology, as well as endocrinology. What are your thoughts in given the scope and capacity in which you practice about primary care, particular, and their focus?
So I feel like once a patient gets to me, it's my job to figure out what's been done with the patient's metabolic risk factors and who's managing them. And I find oftentimes it all is resting with primary care. Many of my patients haven't been referred to any specialty, and yet they have type 2 diabetes that's not well managed. They have perhaps cardiovascular disease that's not been discovered yet. And they definitely have lipid issues that aren't being addressed as well. And so I have to think of that when I see a patient. I would like to jump right into the liver realm, but once again, it's not always just about the liver for me as much as I wish it would be.
Fernando, what do the different society guidelines say about initial screening for MASH? And do you agree with them?
Yeah, let's dive a little bit into the details. So we've known that in the last few years, we have several guidelines or clinical care pathways suggesting that it's important to screen for liver fibrosis in patients at risk. But what's the definition of at risk? It's a little bit hit or miss based on what guidelines you follow. So they agree on many things that we need to screen for patients that are at high risk, but the specific populations, they change from guideline to guideline. But if you put them all together, you can see that we all agree that patients with type 2 diabetes are at high risk and we need to screen for liver fibrosis in those. Obesity plus cardiometabolic risk factor, at least one of those. Also, all guidelines agree. And then most guidelines agree that if you incidentally are found to have steatosis by any imaging, or if you have elevated liver enzymes, those are populations that are at risk for clinically significant fibrosis, and therefore we need to screen in those populations. And if we look at what they recommend, so they all agree that FIB4 is the first step, and I do agree that FIB4 is widely available and therefore a good starting point. But I do agree with what Anne said earlier. So if you're in a specialty practice and you have FibroScan or a BCTE available, then I think it's reasonable to skip FIB4, and that's what the latest AGA clinical care pathway endorsed, at least in patients with type 2 diabetes. They all agree that once FIB4 is elevated, we need to do confirmatory testing, but then the thresholds vary a little bit from guideline to guideline.
Yeah. So, fortunately, the ASLD has championed guidelines for risk stratification screening and defining a care pathway. And you'll see that there's a lot of overlap here between the workflow of primary care and even gastroenterology and hepatology, with the first risk stratification, as Fernando has pointed out, being that FIB4 score. Now, a FIB4 score under 1.3 has a very high negative predictive value to exclude the presence of advanced hepatic fibrosis or cirrhosis. And these patients can be very comfortably followed in primary care and reassessed every 1 to 2 years, or even 3 years if there's no presence of metabolic syndrome or diabetes. But for high risk patients with diabetes, a recommendation of every 1 to 2 years. But those patients with intermediate stage levels of FIB4 can obtain a second risk stratification, such as an ELF score or a elastography, whether that's by VCTE, vibration controlled transient elastography, or by MR elastography, which are typically present in hepatology practices or in tertiary care centers. But a referral pathway, certainly for those patients with elevated FIB4s above 2.67, which would allow a specialist to really ascertain the presence or absence of cirrhosis with a more sensitive platform such as MR elastography, or ensure that there's no competing diagnosis, deliberate the potential need for a liver biopsy, although we have been moving to performing less liver biopsies in clinical practice, and really taking more ownership of those patients with advanced hepatic fibrosis, cirrhosis, or maybe even an early portal hypertension. And for patients who prove to have very mild liver disease, referring them back to primary care. And for patients with fibrosis stage 2 or 3, even entertaining liver directed pharmacotherapies early in care pathways. How are the endocrinologists thinking about this?
I think in a similar way. So we know we are seeing an enriched population because mostly we see patients with type 2 diabetes, obesity. So we know that the risk is higher in this population. So we also think, well, we need to screen more. We use the FIB4, and then depending on the results, whether we want to order some confirmatory testing, or if the the FIB4 is below 1.3, well, as you said, it's a high negative predictive value. But I would also counter argument that, so these algorithms are good, but at the end of the day, it all goes to the patient you have in front of you. So if you think the patient is high risk, you calculate FIB4, but you still have this feeling that this patient is really high risk. You see AST higher than ALT. So again, you can think a little bit outside of the algorithms and try to focus on the patient, and maybe just order confirmatory testing, because patients with type 2 diabetes, they tend to be really high risk. And sometimes we may miss them with FIB4, unfortunately, even when that negative predictive value is high.
So take us back to Miss Jeannie here. What unfolded for her?
Yeah, so let's calculate FIB4. So we use information from age, AST, ALT, platelet count. FIB4 was 2.4. So even if you use the alternative cutoff point of 2 for patients older or 65 or older, you see that she has an elevated FIB4. So what do we do next once we know her FIB4 is elevated? Well, we said this is just the first step, and we want to confirm this with confirmatory testing. And this can go, depending on your availability, some kind of elastography. It could be VCTE, if that's what you have available. It could be share wave elastography, ultrasound elastography, or MRE. So it depends a little bit of what you have available. It could also be a blood test like enhanced liver fibrosis or ELF. So in this case, we did PCTE, and it showed a control attenuation parameter of 380 and a liver stiffness measurement of 11.9 kilopascals.
So clearly, this patient has an elevated CAP score consistent with hepatic steatosis, as well as an elevated, at least liver stiffness measure of 11.9 kPa by VCTE, which would be concerning for me about being in a target range of at least clinically significant hepatic fibrosis F2, F3. And I would really be considering whether she needs liver-directed therapy for not only targeting her metabolic syndrome, but also her underlying liver disease. Um, I would you initiate therapy, and if so, which one, Dr. Brill? GLP-1, and how often and would you utilize GLP-1 even independent of the knowledge of her underlying liver disease, or does the knowledge of her liver disease change that?
I think she has an indication for a GLP-1 independently of her liver disease. She has a BMI over 27, a known coronary artery disease. So, based on data from the SELECT trial, we know semaglutide is approved to treat cardiovascular disease in patients with BMIs over 27. So, I do think she has an indication for it. But now, knowing that she has liver disease, well, that reinforces the concept that yes, there's benefit here not only for cardiovascular disease, but also for the liver. So I do think she fulfills the criteria in my mind where she would benefit from starting therapy.
So, and she's going to come to you now because Dr. Brill thinks she clearly needs and has indication for GLP-1, but has this elevated liver stiffness and does trickle into a liver clinic. What are your thoughts about the role of resmetirom now at this juncture, or even starting it independent of the GLP-1?
Sure, I certainly agree with Dr. Brill that she's a candidate for GLP-1s, but I'd like to keep resmetirom in my back pocket there too. So I sometimes feel like starting two therapies simultaneously is not a good idea. I like to start one and let them settle in a little bit and then consider the next if there's not the improvement that I'd like. And so I feel strongly that this patient's going to benefit from a liver targeted therapy. But I'll let Dr. Brill start his GLP-1 first in this case, I think.
Well, maybe you can tell us a little bit about these approved agents for MASH, Ann. What are your thoughts about the resmetirom and semaglutide, and what
Sure.
are they?
Boy, we waited a long time for an FDA approved MASH therapy. And finally, in March of 2024, um, resmetirom got accelerated approval by the FDA for MASH with moderate to advanced fibrosis, stage F2, F3. So our case, Jeannie, fits in that category for sure. Now, resmetirom is a thyroid hormone receptor beta agonist. It is liver targeted therapy. It selectively activates THR beta cells in the liver. Um, it it mimics thyroid hormone action sort of in the liver. It turns on the liver's metabolic engine, if you will. It promotes fat breakdown and it improves cholesterol handling. We've had 2 years of real world experience now with some pretty promising results, and the clinical trial is ongoing in their open label extension. And then we have the new kid on the block in terms of MASH management, and that's semaglutide. And it was FDA approved just in August of 2025. So only around for 8 months in terms of approval for MASH. But we are very familiar with this agent for other disease processes, type 2 diabetes, obesity, coronary artery disease, sleep apnea. So MASH is now on the list, and I'm happy to have it because it's making it a little bit easier for me in hepatology to get a GLP-1 approved by insurance.
Yeah, and with that being said, and well said, the nice thing is we have two approved therapies. And it's important to note that the ASLD has issued two guidances for use of both resmetirom and semaglutide. And these guidances are very well aligned. So the recommendation is to risk stratify and identify those patients who have at least intermediate stage liver disease, fibrosis stage 2 or 3, and there are guidances with regards to these various blood based biomarkers, imaging based biomarkers, or even histology that has historically demonstrated fibrosis stage 2 or 3. But if we were to target a liver stiffness by BCTE of 8 to 15, or an MRE of 3.1 to 4.4, this patient, Janine, would be a candidate for either resmetirom or semaglutide or potentially even both in a sequential order if she came to my clinical practice also having already been on a GLP-1 and has persistent evidence of liver disease. I would also consider adding potentially resmetirom. Now, other patients that may be considered for resmetirom or semaglutide are those that have VCTEs that may broach the F3 fibrosis stage a little higher in their VCTE or MRE liver stiffness, but without being excessively high that it risks having cirrhosis. Neither one of these agents are approved for the indication of MASH related cirrhosis. So we have to be very cautious about patients who we know have cirrhosis, may have portal hypertension, and certainly with use of GLP-1, any history of medullary thyroid cancer or MEN2 syndrome. And we also don't want to be starting resmetirom in patients with uncontrolled thyroid disease. So we have an armamentarium, and if you know one of these recommendations for use, you will be able to use both therapies effectively. Dr. Brill, what are the thoughts with regards to positioning of endocrinology in those that you're seeing who have both obesity and diabetes in context of positioning MASH pharmacotherapies?
Yeah, I think in that regard, because we tend to see patients with obesity and type 2 diabetes. If you ask me, we are more inclined to start GLP-1 as long as there are no contraindications, just because we think of liver disease as a systemic condition uh, where adipose tissue is dysfunctional, insulin resistant, and that accumulation of fat happens everywhere. So the liver has an enormous capacity of accumulating fat, can lead to liver fibrosis, but there's a ectopic fat accumulation in the skeletal muscle, in the heart, in the pancreas, in the kidney. So in that setting, I think we usually see those patients that benefit the most by just targeting that increased adiposity, and therefore we are usually more inclined to start GLP-1, knowing that this is a metabolic condition, and most of the time these patients may need combination therapy. So when you ask me about that sequential starting of medication, I usually, as long as there are no contraindications, GLP-1, and then reassessment. And I think that's where the ADA guideline is trying to go, where you focus on obesity, focus on diabetes, and then also think of the liver, because it may not be enough with that starting that GLP-1.
So, do you want to bring us back to the case?
Yeah. So you see her after 7 months of follow up. She was starting on semaglutide, uh, but you had to reduce the dose to 1 milligram weekly because of nausea. She's tolerating 1 milligram weekly. Well, she lost 7 pounds after these 7 months of therapy, and that is about 4% of her body weight. You see her again after 15 months of the initial visit. She's now on semaglutide 1.7 milligrams weekly, and she has tolerated that dose for 3 months. Only a little bit of constipation, but no complaints. She lost an additional 4 pounds, and that's a total body weight loss of 5.9%. This is something typical we see in clinic, where you slowly are able to get your way up on semaglutide, but it may take you a little bit longer due to some GI side effects. So you are at the mark of over a year, 15 months from the starting semaglutide. You decide to repeat the BCTE, and you find that now her liver stiffness measurement is 13.7. So I'm calling Anne right away. So what should I be doing?
Well, I have resmetirom in my back pocket here. Yeah, I did from the beginning. So I see that VCTE and I'm a bit worried. Do I trust that it's accurate? The IQR is up a bit. I take a look at that, but I feel fairly confident that I want to add resmetirom onto the GLP-1 for this patient. I think it could add added benefit in terms of fibrosis resolution, and I think she needs an added boost here.
So yeah, I agree with that. So as I said, metabolic conditions are hard to treat. She didn't have at least her response in weight loss was not what we had expected. Let's say a total of, I think we said 5.9% weight loss. So maybe some benefit, but not to the point where we could see a liver benefit. Definitely a patient I want to still keep on GLP-1, even when I didn't see a BCT improvement, just because it contributed a little bit to weight loss. So there may be metabolic benefits that she's achieving with the GLP-1.
So, Anne, clearly complex patients, a lot of things going on metabolically. What does a multidisciplinary management look like for this patient, and who is involved, and what are their roles?
So I feel like multidisciplinary management looks different depending on where you practice a lot of times. So if you're in an academic or hospital based system, you may be fortunate enough to have the whole team at your fingertips, right? If you're out in the community, it's making the connections with the key players in your area in terms of the team that you want managing your patient and what their cardiometabolic risks are. In rural settings, it may just be you, and you may have to seek out mentors to guide you in the management of these patients, right? But no matter where you are, I feel like the goals remain the same wherever you practice. Lifestyle modifications as the foundations, with that 5 to 10% weight loss as a goal. Risk stratify early and keep doing it because, as you saw in our case, that patient wasn't where we wanted her to be, and we have more options now, right? So early and in an ongoing fashion in terms of risk stratifying. And I feel like MASLD is a relapsing and remitting disease, and patients can kind of go back and forth on it's not just a straight train to cirrhosis for these people. They can get better and then they can get worse, right? So it's keeping an eye on them, knowing how to stratify what their risk is at the current time, and then coordinating care, super important.
Yeah, you mentioned this foundational role of diet and lifestyle modification, particularly weight loss in managing NASH. Can you discuss this with us in a little bit more detail?
So, MASLD is really tightly linked to conditions like obesity, insulin resistance, metabolic syndrome. In essence, MASLD is really driven by how the body handles energy. So, when you improve your diet, your activity, and your weight, you're addressing the root cause of MASLD. So, that's the goal here. We're fortunate to have medication we can use in conjunction with lifestyle modification. But I'm just going to hammer home that when I talk to patients about weight loss, I like to stress that it doesn't take too much to make a difference in liver health. So even if 5% weight loss can start removing fat from the liver, and in fact, if you're on resmetirom already, a 5% or higher weight loss has been shown to enhance the impact of resmetirom. We saw that data come out at ASLD this year, which was really fascinating to me. So um, lifestyle modification in conjunction with pharmacotherapy can be the best option for our patients. How you achieve that weight loss has to be individualized. We have the most data with the Mediterranean diet, but with my population, that diet is not a cultural fit. Let me just say, I have to I have to talk about reducing refined carbohydrates and sugars like sugary drinks, ultra processed foods, along with portion control as the initial step. And you can fit that into any cultural, whatever they're eating, we can work with that, right? So I think that's really important. The same goes for activity, in that we want moderate aerobic activity with some resistance training as our goal, but you have to do it one step at a time. Our patients are very inactive a lot of times, and you can't say 150 minutes of aerobic activity a week and have that be a healthy option for them. Actually, sometimes it's just increasing the steps per day, but you have to really individualize the care. I think the bottom line to all of this is that lifestyle change is not just advice, it is disease modifying therapy in MASLD. And we have to think of it like that, because otherwise patients just are like, I'll take the meds and I'm not going to worry about my lifestyle. And I think that's the wrong attitude. I think the real challenge lies in sustainability with these patients because many of them know what to do. It's just difficult to sustain it. So small, consistent changes over time beat short-term extremes every single time. And I think that philosophy, like our patient who lost 7 pounds in 7 months, that's okay. She's losing, right? So small changes are sustainable. And then supporting with education and encouragement along the way, and you're going to hit those targets. So that's a
Yeah, no,
that's a mouthful,
I
a short
agree
time.
totally. And sometimes I have to have the discussion that improvements in MASH can be done even independent of weight loss, just making the dietary changes, avoidance of ultra processed foods and sweetened beverages, and improving physical activity even independent of weight loss. I would go so far to say any patient with advanced hepatic fibrosis or cirrhosis needs complete abstinence from alcohol
Oh, I
consumption.
forgot my
Fernando,
alcohol. Absolutely.
yeah. Okay. Fernando, do you have any other thoughts about discussions you have on a multidisciplinary platform?
No, I think so. For the multidisciplinary approach, we need to increase communication among different specialties. There's a lot of things that we can all be prescribing. So we just need to understand our roles, and that requires communication among providers. And then going to lifestyle, we know the rate of success of lifestyle long term is relatively low, but that, if anything, should encourage us to be stronger and focus even more. So it shouldn't discourage us. The fact that over 10 years, usually our success rate is relatively low.
Well, Fernando, Ann, this has been a great discussion. So, with that, I thank you both again for joining me today in this discussion and hope that it was beneficial to our entire audience. And to our audience, thank you for participating in this activity. Please continue on to answer the questions that follow and complete the valuation. Thank you.